The video, Laser Ablation Technique in Plumber's Adenoma, Equipment and Details of Technique, aims to present the preparation of the operating room, the necessary devices, treatment planning, and the treatment in cases of plumber's adenoma. The gold standard of benign and malignant thyroid diseases treatment is surgery, but since the early 2000s, mini-interventional methods and laser ablation have taken up more and more space in the treatment of thyroid pathologies. Surgery carries a higher complication rate. Laser ablation can be used to treat symptomatic benign nodules, hyperfunctioning nodules, microcarcinomas, and lymph node recurrences. Laser ablation has the advantage of performing necrosis areas, even of small dimensions, in total safety. The aim of our video is to provide a short guide that introduces the preparation of the operating room, the necessary devices and treatment planning. In the second part of the video, however, we will present the laser ablation treatment of a plumber's adenoma. All instruments must be sterile prepared. Antimicrobial disinfectant, sterile gauze, 3 sterile drapes, 20 cc syringe containing anaesthetic solution, needle with a calibre of 25G and 7 cm long, sterile gel, probe cover, laser fibre with 21G introducer needle, specific bracket for the probe, and 4 guides with different angles, 60 degrees, 65 degrees, 70 degrees and 75 degrees. The bracket is placed on the ultrasound probe and then covered by the sterile protective cover. The guide is placed on the bracket. The angle is decided during the programme. Each guide has 5 accesses for the guide needle. The first access is the most superficial. Gradually, the 5th access is the deepest one. The sterile field is prepared with an antimicrobial solution. The case presented is of a 53-year-old woman with plumber's adenoma receiving 10 milligrams of methimazole per day. The patient presents mild exophthalmos, tachycardia, night sweats and poor control with medical therapy. The ultrasound phase begins. The size of nodule is calculated with ellipsoidal equation. We proceed with the study of vascularisation at colour Doppler and power Doppler. In our case, the patient has both intra and perinodular vascularity. Transcutaneous laryngeal ultrasound is done prior to the procedure. The movement of the true and false vocal cords is evaluated during spontaneous breathing and phonation. During phonation, the vocal cords appear as hyperechoic vibration in midline. The treatment is planned. The probe is placed longitudinally. The planning is activated where the 5 lines that correspond to the 5 accesses of the guide needle are shown. The energy to be supplied is chosen, which varies from 1200 to 1800 joules for each lighting of the fibre. As in this case, the pullback is planned, which varies from 0.5 cm to 1.5 cm. The pullback technique is used in the treatment of lesions with a major axis greater than 2 cm. The technique allows the enlargement of the ablated area. The pullback technique allows the guide needle and the optical fibre to be retracted by 0.5 centimetres, 1 centimetre or 1.5 centimetres and to proceed with a second illumination of the fibre. One or two pullbacks can be performed during the procedure. The pullback must be programmed during the planning phase in order to respect the blue area, which is the safe area where necrosis is carried out. Once planning is complete, a pericapsular and a subcutaneous anaesthesia. The local anaesthesia was performed with 2% lidocaine. The optical fibre is connected to the generator. The power range is from 2.5 to 4 watts, depending on the nodule's volume and position. In our case, we are using 4 watts of power. The patient must put on protective glasses. The optical fibre is inserted through the guide needle into the target nodule. We insert the guide needle on the 3rd line as per programming. The guide needle appears hyperechoic. The active fibre produces a hyperechoic area. The necrosis appears hyperechoic due to the micro bubbles created by the evaporation of liquids. During the procedure, the patient can speak without making any movements. It is evident that our patient did not feel any kind of discomfort. At the end of the procedure, the fibre is removed together with the guide needle. A transparent dressing is affixed, which allows for post-procedure ultrasound control and ice. At post-treatment vascular control, the lesion appears completely avascular at both PD and B flow. The treatment can be considered concluded when the volume of the hyperechoic area remains stable. The evaluation of the treatment's effectiveness is performed through the Doppler analysis. The real volume of the area subjected to ablation can be determined 72 hours after the end of the treatment, as the cell damage becomes permanent. The motility of the vocal cords should be checked with transcutaneous laryngeal ultrasound at the end of the procedure. At the 1-month follow-up, we recorded a volumetric reduction of about 20%. The necrosis area appears hyperechoic. The biohumoral tests have normalised, and our patient is pregnant after 7 years of infertility. Due to the pregnancy, we were unable to perform a scintigraphy. Thanks for your attention.